We've talked before about psychiatric medications and the risk for QT prolongation or torsade de poids. As a reminder, torsade is a lethal polymorphic ventricular arrhythmia. It is associated with sudden cardiac death. In other words, some individuals who experience torsade don't have any warning symptoms. They just drop dead. That's pretty scary. The other concerning feature of torsade is that it's highly recurrent, even in the short term, meaning that although torsade frequently resolves on its own or responds to magnesium, it also frequently recurs within minutes to hours, sometimes repeatedly. Unfortunately, there's no great way to predict who will develop torsade. Currently, it's thought that QT prolongation is the best approximation of risk for torsade, though it's important to keep in mind that the relationship between the two is quite inexact, with some medications, like amiodarone for example, causing significant QT prolongation but almost never being associated with torsade. A host of psychiatric medications have been associated with both QT prolongation and a risk for torsade. It's been said, in fact, that the risk for QT prolongation is the most common reason why new medications are rejected by the FDA. This is kind of amazing to me, considering what a rare and unpredictable event torsade is, with rates somewhere between 1 in 12,000 and 1 in 120,000. This month, we're examining a new study looking at whether antidepressant and antipsychotic medications increase the risk for torsade. I'm Scott Beach, and this is Quick Takes for the Psychopharmacology Institute. Today's study was published recently in General Hospital Psychiatry. It's a case control study. The authors took 110 cases of torsade and matched them in a 3-to-1 ratio with 330 controls. Controls were identified by the 3 most recent EKGs prior to the case of torsade and were not matched on any specific criteria. The authors then examined 8 variables to determine which of those were associated with an increased risk for torsade. The major takeaway from this study for our purposes is that monotherapy with antidepressants or antipsychotics was not associated with torsade, nor was age or hepatic or renal failure. On the other hand, the use of 2 or more antidepressants was associated with torsade, along with the use of other QT prolonging agents, female sex, left ventricular dysfunction, acute MI, and hypokalemia of less than 3.5. Notably, the use of 2 antidepressants carried the lowest relative risk of these significant risk factors. There was also a non-significant trend towards the use of 2 or more antipsychotics being associated with torsade. Medications were counted if they were administered in the 5 days prior to the event. Let's unpack this a bit. The use of antidepressants in general was not associated with torsade, nor was the use of antipsychotics. That's pretty consistent with what we know from other literature. Even for psychiatric medications that have the potential to cause the most QT prolongation, and as a reminder, that's citalopram among the SSRIs, and ziprasidone, iloperidone, and thioridazine among the antipsychotics, even for those medications, an association with torsade or sudden cardiac death is not commonly found, in part because torsade is such a rare event at baseline, and in part because the degree of QT prolongation with these medications, somewhere between 10 to 20 milliseconds in most cases, is not significant enough to meaningfully impact clinical outcomes for most patients. Even very large studies involving millions of patients have generally not found an increased risk of ventricular arrhythmia or sudden cardiac death with medications like citalopram. The study did find, however, that the use of 2 or more antidepressants was a significant risk factor for torsade, and that the use of 2 or more antipsychotics approached significance as a risk factor. The idea of polypharmacy as a risk factor for torsade has been raised previously, and at least for antipsychotics, it was generally concluded that it was the cumulative antipsychotic dose and not specifically the use of 2 different medications that led to the increased risk. The idea that 2 or more antidepressants increase the risk is a little more novel. The authors hypothesize that perhaps the use of 2 antidepressants indicates greater severity of illness which itself could be a risk factor for adverse cardiac outcomes. An interesting note with regards to antidepressants in this study is that the antidepressants most likely to be used as augmentation, bupropion, mirtazapine, and trazodone, were also most commonly prescribed in cases of Torsades. The authors don't really speculate on the connection, but it does make you wonder if there is something about these medications that is standing out with regards to cases of Torsades, both in terms of monotherapy and polypharmacy. Now, bupropion has been pretty well exonerated from causing QT prolongation at this point. When a signal does show up, it seems to be an artifact of tachycardia and the use of Bazette formula to correct. The picture with mirtazapine is a bit cloudier. One prior study did link mirtazapine to a greater risk for sudden cardiac death, but the authors hesitated to make a causal association. Interestingly, a lot of cardiologists have come to believe that mirtazapine is safer in this regard than SSRIs, though there doesn't seem to be any evidence to actually support that comparison. Trazodone, on the other hand, doesn't have a big signal in the literature for Torsades, but it was the subject of a surprising study in 2020 showing QT prolonging effects more significant than the numbers typically associated with ziprasidone. In the end, this particular study today doesn't convince me of anything related to these particular medications, however, because the N is too small and because the study was not powered to detect signals with individual agents. The finding with regard to the so-called other antidepressants could very well be random and related to a failure to correct for multiple comparisons. Nonetheless, it's intriguing and may be worthy of further investigation. Also worth noting here is that the Bazette-corrected QTc interval in cases of Torsades was 501 milliseconds, compared to 448 milliseconds in controls, which does suggest some correlation between QT and Torsades. Keep in mind, though, that it's important to resist the urge to assign a random QT cutoff for risk. While many of us were taught to only worry above 500 milliseconds, Torsades can occur at lower QT values, and conversely, many patients with a QTc greater than 500 or even 550 milliseconds will not experience Torsades. Unfortunately, the authors didn't include bradycardia among the 8 risk factors they examined, which is a shame because bradycardia is often considered to be the most important risk factor for Torsades, and may be relevant here because many psychiatric medications have a slight increase effect in heart rate. Reassuringly, only 2 out of 110 patients in the study died of Torsades. That's a pretty low rate, though it's important to keep in mind that patients were in a controlled environment, and the study did find that patients who suffered Torsades had an overall higher mortality rate by about 3-fold compared to controls. So, where do we go from here? I would say further studies are needed to better examine the connection between the risk for Torsades and the use of antidepressant or antipsychotic polypharmacy. But today's article does raise some good questions in that regard. In the meantime, how do we protect patients who have multiple risk factors for QT prolongation and/or Torsades, but may need psychiatric medications that carry a risk for these outcomes? There's an interesting development out of the world of psychedelics. Ibogaine is a psychedelic that's used for addiction. It's not approved in the US, but several clinics around the world use ibogaine to treat opioid and other substance use disorders. Ibogaine has significant QT prolonging properties, and there are many reports of people dying from sudden cardiac death in the setting of ibogaine treatment. This problem was concerning enough for a while that it looked like ibogaine might never gain widespread use. More recently, though, a protocol has been developed for ibogaine that involves giving patients high doses of magnesium prior to treatment. This seems to be quite protective against Torsades, and while further studies are needed, the early data seems promising. Perhaps a similar protocol will eventually be a reasonable option in situations where, for example, a patient in the ICU with multiple risk factors for Torsades requires antipsychotic medication for control of agitation. Such an approach could someday complement our thorough risk assessment and close cardiac monitoring.